Good afternoon, everyone, and welcome to today's webinar, Demystifying Palliative Care from the After Lunch series with your MGH ALS nurses. My name is Judi Carey, and I'm the Research Access Nurse at the Healy Center for ALS at Mass General. And today I am happy to be joined by Dr. Kate Brizzi, our ALS Clinic's Neuro-Palliative Care Doctor, as well as my research nurse colleague, Hannah Zivalic from the Healy Center. Dr. Brizzi will be sharing her expertise on the topic of palliative care and how it relates to an ALS diagnosis. So before she begins, I will go quickly through a few housekeeping slides that explain disclaimers. And also at this time, I would like to remind you to please mute your microphones. So the medical disclaimers, so the decision about whether to try any of these recommendations is a decision that you should discuss with your ALS care team. Today's presentation is meant to share information we have learned about palliative care that may be helpful to you. In mentioning certain ideas, it does not mean that we are telling you to do all of these things. Rather, we are informing you of some recommendations that are shared with our patients. The information from the webinar is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information, is for general information purposes only. We encourage you to confirm any information obtained from or through this webinar with other sources and review all information regarding any medical condition or treatment with your own provider. Never disregard professional medical advice or delay seeking medical treatment because of the information provided in this webinar. For privacy disclaimer, during this presentation and question and answer session following, if you choose to type a question in the chat box, please know that other attendees may be able to see your name and question. Please check your audio and video settings on your computer when you enter the webinar, as you may be heard by others or visible on our shared screen. We share this information with you to be mindful of your own privacy preferences. So we like to talk really quickly about how the After Lunch series came to be here at Mass General. So we nurses will lunch together and talk about clinical care of our patients so that we can each learn from one another. We decided that it would be a good idea to share our conversation via webinar platform with patients and caregivers inside and outside of Mass General, thus creating the After Lunch series to incorporate the letters ALS. We then invited our colleagues, such as Kate Brizzi, who also help to care for our patients and to help share their expertise with us. We are providing this as a teaching tool and a resource guide. These webinars will continue to be available on the MGH ALS website for future viewing at the link provided. And at this point, I'm going to turn over the webinar to Kate Brizzi. Thanks, Kate.
Great. Thank you so much, Judi. It's really a pleasure to be here today and be talking about a topic that is very near and dear to my heart. Today we're going to be talking about palliative care, and hopefully I'll be able to define this for you and talk about how it can benefit both patients and family members. We'll talk about what actually happens in a palliative care clinic visit, and we'll talk about the difference between palliative care and hospice, as that's a frequent question that comes up. A little bit about me, just to provide some background. So I am dually trained in both neurology and palliative care. I'm called a neuro-palliative care specialist. I have been fortunate to be here in Boston for my training and now my practice. I work as an embedded provider within the MGH ALS clinic, and what that means is that I'm essentially part of the multidisciplinary team, seeing patients alongside the physicians, nurses, nurse practitioners, physical therapists, speech therapists, everyone that's part of our important team. So to start off today, I'd like to make sure that we're all on the same page regarding some definitions. So how do we actually define palliative care? There are a lot of different definitions if you look online. The one that I actually like is this one. It comes from the Center to Advance Palliative Care. And what they say is palliative care is specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. I really like this definition for several reasons. I like that it puts emphasis on both the patient and the family members and people that are important to them. Additionally, really the emphasis here, as you can see, is on improving quality of life and really reducing symptom burden. And that is a lot of what we do in palliative care. The palliative care is a collaborative effort, and in palliative care, we end up working alongside other treatments. So as a palliative care specialist, I'm integrated within the team, and while patients are getting care from their ALS physician, I'm also helping support that care. In palliative care, we really emphasize a team approach. There are many different types of ways that palliative care can be delivered, and we'll talk about that a little bit later in the talk. But in many palliative care clinics, we actually have a multidisciplinary team in and of ourselves. There are often physicians, nurse practitioners, social workers, and chaplains that work as part of a palliative care team. The goal of a palliative care provider is to alleviate suffering. And the thing I really hope that you take away from today's talk is that palliative care is appropriate at any stage of a disease. Even at the time of diagnosis, palliative care can work alongside other treatments that you're receiving to make sure that we are maximizing quality of life at all stages of disease. As far as the benefits of palliative care, there are a number of them. We don't have a lot of studies looking at palliative care specifically within a population of people that have ALS. However, we do have a lot of research looking at palliative care in other fields. For example, in people who have cancer or people who have conditions that affect their heart. And what we've seen in the studies that have been done, we see that palliative care, when that is a part of the treatment plan for a patient, is associated with significant improvements in quality of life and symptom burden. We also see that palliative care helps to improve the lives of caregivers and family and loved ones. And we see improved caregiver satisfaction and improvements in mood for both patients and caregivers. Interestingly, actually, some studies have actually shown a longer survival for patients who have palliative care. A lot of this comes from work that was done in the lung cancer population, and what they did was they had basically patients who had early diagnosis of lung cancer. They had palliative care get involved very early on, about at the time of diagnosis, and the palliative care specialists helped work alongside the rest of the treatment team. And what they found was actually that the patients who were receiving palliative care actually lived longer than the patients who were not. And we can certainly talk about that later as well if there are questions about that. So it often comes up when I'm talking to patients and their family members, they often ask about what the difference is between palliative care and hospice. I think that these terms are often confused. And they're actually quite different, and I think it's just important to kind of point out some of those differences. So palliative care and hospice both do share a common philosophy that they are really working hard to help to relieve any symptoms. Both of them are really focused on making sure that we're improving kind of quality of life. However, there are important differences between the two. Palliative care can be delivered at any stage of disease, meaning from the time of diagnosis onward. Hospice tends to be an intervention that is put in place in the setting of advanced disease. Palliative care is able to be delivered alongside other treatment approaches. And then in the setting of hospice, really hospice, the focus is really on comfort-directed therapies and therapies that help toward that means. Palliative care is typically administered via intermittent visits with either a physician or a nurse practitioner or another provider. In hospice, patients receive frequent visits by nurses or physicians, often to their home or to wherever they may be. People often ask too about how palliative care versus hospice is sort of paid for. In the setting of palliative care, it's typically paid for through insurance, whereas hospice is typically a Medicare benefit. Sometimes it's paid for by Medicaid or insurance. But again, just to highlight, the key difference is, palliative care really is something that can be involved throughout the course of a treatment at any stage of disease, even starting from the time of diagnosis, to really help support our patients and families and help everyone to live well. And it is something that can be done in conjunction with the other therapies that patients are receiving. So what actually happens in a palliative care clinic visit? So in the sort of earlier visits, a lot of what we're doing is also just trying to get to know you, getting to know the patient. And so my goal when I go into a visit, with a patient is really to get to know them as a person, not just as a patient. I want to know about the things that are important to them and the things that they value. We'll also go through different types of physical or emotional symptoms that you might be having and think about strategies for how we can work on these. The different types of physical symptoms that we can address really range. We often end up talking about things like pain. We talk about things like excess saliva. We talk about things like constipation, things like muscle spasms. We talk about also emotional symptoms such as depression or anxiety. So these are all types of symptoms that we can address at the time of our visit. We'll also talk about your goals, the patient's goals and hopes for the future, and think together about strategies for how we can help. And importantly, we also talk about how the patient would like to receive information. For example, is the patient someone who likes to hear all of the details about their medical care? Are they somebody who prefers the big picture? Are they somebody who prefers to really kind of focus on living in the moment versus somebody who really wants to be planning? We'll talk about all of those things in our visits so that we can make sure that we best address the patient's needs. I want to emphasize that, during these conversations, the patient is really in the driver's seat. I think a lot of times people feel anxious about the idea of meeting with palliative care and are worried that we're going to be talking about things that might be hard or scary. I want to just say that, the patient is really in the driver's seat, and how much we talk about and what we talk about is really a discussion and is up to the patient and their loved ones. We are very much flexible in that and can work on whatever you feel like would be most of benefit. We also make sure that you're comfortable with who is present for the conversations. Some people prefer to meet with the palliative care doctor by themselves. Other people prefer to have family members present. And then, similarly, how information is presented, the way that we talk about information is something that is also in the patient's control. And so, really this is a collaborative effort between the provider and the patient to figure out how we can best be of help. Other things that we can do in our visits, if these are of interest, to patients and family members, is that we can help with thinking about decisions related to medical care. There can often be different questions that people may have about how their disease might affect their functioning in the future or living situations, and that's something that we can talk about together and strategize about together. We can also talk about, possible medical decisions that may arise in the future. And certainly we can help with thinking about advance directives or healthcare proxies. If you're not familiar with those terms, a healthcare proxy is someone that you designate to make medical decisions for you if you're not able to for some reason. I actually recommend that everyone has a healthcare proxy because it's a good practice to just make sure that we know who should be asked if any medical decisions are needed to be made in the future and for some reason you're not able to make them. Advanced directives, if you've heard about different things like power of attorney or living will or things like that, these are the types of things that come up with advanced directives that patients sometimes have questions about and aren't sure who to ask about these questions, a palliative care specialist has a lot of training and can talk about these in more detail. So I want to just step back for 1 second and talk a little bit about kind of why these conversations are important. We've been talking for the last few slides about the different types of discussion topics that might come up in a palliative care visit. And so sometimes people ask, well, why do we have to be talking about these things, or why should we be talking about these different types of questions? You know, I could actually provide you with a pretty long list about this, but I have a few ideas up on this slide. You know, I think these conversations are important for a number of reasons. You know, first off, understanding what a patient's goals and values are really helps to improve communication between the patient and the provider. And I think for us, you know, as your team taking care of the patients that we see, that having that information about what's important to our patients, what their goals and values are, allows us to help make really tailored recommendations to that particular patient. There's also a strong body of evidence that suggests that having these types of conversations, especially with caregivers and family and loved ones present, that can actually reduce stress for loved ones and for caregivers. It takes some of the question marks out of care and helps people to understand what is important to someone, and allows them to not feel like they're making any guesses in decision making if they were put in a position where they would have to make decisions in the future. The clinic itself, and we'll talk about the many different ways that palliative care can be delivered, but the clinic and the space where we talk about these types of important conversations, you know, our goal is really to provide a safe space for these conversations, and we hope that it'll be an opportunity to take some time to step back and think about planning ahead. So again, these conversations, I think they're important for a number of reasons, and I could probably keep on going with this list. But I do think that it really helps with communication with your care team, communication with your loved ones, and really can help us to make better recommendations for you. Sometimes people tell me that, you know, they are very interested in these conversations and that they would like to talk more as a family, separate and outside of the clinic, about some of the things that are important to them. There are a number of different resources for doing this. I've listed 2 that are up here on this screen that you might want to consider checking out. There's the Conversation Project and 5 Wishes. Both of these are essentially conversation guides that can help patients and family members sit down and talk together about their goals and values and the things that are important to them. I highly recommend checking out one of these and finding a good time to sit down with others and talk about these conversations. These are also conversations that you can then bring back to the clinic, and we can reflect on these together if that's of interest to you. So when is the right time for palliative care? I'm hoping that you all know the answer to this after hearing some of the talk, but it's any time. Again, palliative care is something that we think can be a part of your care even from the time of diagnosis onward. And so I really want to emphasize that today, that we really think that this is an extra layer of support that can be helpful for both patients and their family and caregivers. So who actually provides palliative care? I will say that this varies a little bit depending on kind of where you live and your particular situation. I will say that actually everyone on your ALS team is providing aspects of palliative care, meaning that your physician, the nurses, the nurse practitioners, everyone is providing some aspect of palliative care because they're really focused on helping to improve your quality of life. A dedicated palliative care specialist, someone who has training specifically in palliative care, can really provide dedicated focus to these types of issues, can help with more intensive symptom management, can help with issues such as planning for the future. And so those are reasons why it may be worthwhile to meet with a dedicated palliative care specialist if that's available. There are many different ways to access a palliative care specialist. Not everyone has an embedded palliative care specialist within the clinic, and that's okay. There are, if you're cared for in a hospital or academic type setting, there's oftentimes a separate sort of palliative care clinic that sometimes works together with the ALS clinics there. Additionally, if that's not available, many people have a VNA in their area, and many VNAs actually can provide palliative care services as well. The third route, I will say, is actually that hospices, which we talked about, again, the difference between hospice and palliative care. However, many hospice agencies actually have what's called a palliative care arm or branch. So they have a separate branch that does palliative care, not hospice, that you can access through any local hospice agency. So there's many different ways to access palliative care, and kind of based on the way that you're accessing palliative care will determine sort of geographically where you see the palliative care specialist. Do you see them in the clinic, or are they coming to your home? Are you going to another clinic to see them? It really kind of depends on the way in which you're accessing palliative care. So just to summarize, so palliative care works alongside other ALS treatments to help patients live well. Palliative care is applicable at any time during a disease, even from the time of diagnosis, and works together with the other treatments. Palliative care can help patients plan for the future. I greatly thank you for your attention, and we'll take some questions that we have here. I think, Judi, you have some.
Yep. So thanks so much, Kate. So before we open up for any questions that you may have, Hannah and I are just going to share some questions, commonly asked questions that we receive from our patients.
Great.
And then Kate's going to just give us the answers. So the first question is, does palliative care help with pain management?
Palliative care does help with pain management. So we often are working together with the ALS provider to think about the best approach for pain. But that is actually one of our areas that we do specialize in, is helping to think about the best ways to address pain, thinking about what might be causing pain, and thinking about what might be the best approach, whether it be medications or other types of strategies to help deal with pain.
Okay, great.
And then I have a question, Dr. Brizzi. Why did palliative care extend life in the study you mentioned earlier?
That's a great question. So Hannah's referring to the study that we mentioned earlier that showed that in patients with lung cancer, when palliative care was involved early on in the kind of treatment plan, that those patients had lived longer. So they're still looking into this. The thought is that it's probably in part because the patients who are receiving palliative care in that study were having their symptoms better managed, and it's thought that that was actually what was contributing to, in the long run, helping those patients live longer, the fact that their symptoms were well managed. There's still a lot of study going on, and so they have seen similar results in some other studies as well. We don't have such a study in ALS yet, but I'm hopeful that we will in the future.
And this is Judi again. I'm going to read another question and also just invite anyone who's listening, if they have questions, please feel free to type them. They do pop up on our screen, and I will be able to read them to Kate. So another question we often get is, can palliative care come to my home?
So I think this is, it really depends a little bit about where you are and how you're accessing palliative care services. So certain types of ways that palliative care is delivered does allow for the palliative care provider to come to the home. For example, I talked a little bit about how palliative care can be delivered through VNA or as a branch through a hospice agency. Both of those ways would allow palliative care to come into the home. However, if you're accessing palliative care through a clinic setting, they may not necessarily have that availability. We are also, experimenting with other ways of accessing palliative care here as well. I certainly do sort of televisits or virtual visits with patients as a way to kind of keep and stay connected with patients even between visits.
And Hannah again here, can I just asking, for our patients that ask this question, but can you keep your PT/OT with palliative care?
Absolutely, yes. So palliative care works alongside the other treatments and doesn't supplant those treatments. It's actually done collaboratively with other treatments like PT and OT. So yes, you can keep those services.
Okay. So we do have a question here. Can you please provide specific examples of types of recommendations that the team has made in any category, such as living space, planning for the future? So some specific.
Great. Yeah, so I think to give you sort of an example, so when we think about the types of recommendations that we make, for example, patients in discussions may be about kind of their goals and values, you know, may be talking a little bit about sort of what is important to them and what things that they most value. For example, I'll provide an example that, you know, I had spoken with somebody, and for them, travel was really important, kind of their ability to be able to go out, to be able to do things, and that was really key to this particular individual. And so in terms of thinking about kind of our recommendations as we help that particular individual plan for the future, that was at the forefront of our minds in terms of thinking about strategies where we can really make sure that we keep that goal in mind and help them to achieve that.
Okay. So if we have no other questions at this time, we always like to just welcome you to offer feedback to us, and I provide an email address, alsresearch@partners.org, for any comments about this webinar, ideas for the future webinars. You can always call or email me, and I provide my phone number and email address. For those of you who don't have it, it's jcarey8@partners.org. And we always, of course, are so thankful for Kate when she comes to our clinic and is here today with us.
Thank you so much for having me.
We hope everyone has a nice day. We will be recording this webinar, as we always do, and it will be available in a few days on our newly designed website. So if you have any problems finding it, shoot me an email, and I'm happy to help you locate where the webinars are kept. Thanks so much, everybody. Have a great day.